combining niraparib with bevacizumab. The rationale would be to try to give the patient the longest possible progression-free interval. As we saw, the patient had a recurrence in 2 years and then a recurrence in 1.5 years. It would be very, very nice if the second recurrence were to show up in 3.5 years, because in my opinion, the longer the platinum-free interval, the more likely they are to respond to the reinvigoration of platinum. There was a trial discussed at the recent meeting of the Society of Gynecologic Oncologists in Hawaii, looking at the combination of bevacizumab with a PARP inhibitor. And not only was it well tolerated, but the results were improved with overusing one of those alone in the maintenance setting. I have been using this for several years. I used it before it actually went into the mainstream, including a board member of my Ovarian Cancer Institute who tolerated a PARP inhibitor with bevacizumab for over 1 year without difficulty. With a PARP inhibitor, the GI tract is the Achilles heel. So they should be treated proactively for dyspepsia, for nausea, vomiting, and diarrhea. Fatigue is an overwhelming problem with a PARP inhibitor, so they must be counseled to please push yourself. It's the Cancer Olympics. I want you to go into training. I want you to win a gold medal. They sometimes have rashes. They sometimes have dysgeusia. There's a host of symptoms, but nausea, vomiting, diarrhea, the GI tract, and fatigue are the big problems, along with hematologic adverse events, dropping the platelet count, the white count, and the hemoglobin. With bevacizumab, you have a different group of symptoms. You have problems with proteinuria. You have problems with the pseudoencephalopathy syndrome. Problems with platelet count occasionally, but these do not cross over the PARP inhibitor with bevacizumab. So the combination is actually far better than most of us thought it was going to be. I have had to stop one patient on a PARP inhibitor because of fatigue. Generally speaking, you lower the dose, you have them exercise, and I use Ritalin in these patients, sometimes with very interesting and excellent results. Well, I have to look at their profile, I mean their age, exactly how they might be able to tolerate this regimen. The addition of bevacizumab does provide an added level of concern, especially in the elderly patient. I would want to see that her kidney function and liver function studies were within normal limits. I would look at how they tolerated the chemotherapy, and I might, if they were somewhat fragile, start with the PARP inhibitor and consider, if that was well tolerated, to add bevacizumab at a later date. Things are changing so rapidly. Immunotherapy is being used with greater frequency in gynecologic cancers. Personally, I think chemotherapy is going to have a death knell associated with it in the very near future. It's had a 70-year run since Sidney Farber's legendary work with childhood leukemia in the 1940s. I think it's going to be replaced by targeted therapy, PARP inhibition, immunotherapy, and perhaps other agents that could be added into this cocktail, which would provide a patient with far better statistics and a much better quality of life. Unfortunately, it's unusual for me to be able to find a patient with ovarian cancer where I can use immunotherapy, because you do need to have either a deficiency in the mismatch repair or a microsatellite insufficiency high. And that occurs in only 5% of patients with ovarian cancer, whereas it will be seen in about 16% of patients with endometrial cancer. When PARP inhibitors were first approved, they were only approved for patients with a mutation on the BRCA gene. And one of the great contributions of the NOVA trial was that it showed that patients who were BRCA wild type could benefit from a PARP inhibitor, albeit not as well as those who were BRCA mutated. Maybe the addition of other things to a PARP inhibitor may overcome the need to have a deficient MMR or a high MSI. One of the very interesting papers that emerged from the recent SGO meeting had to do with recurrent cancer of the ovary and the use of pembrolizumab, which is an immunotherapy drug, bevacizumab, and metronomic oral Cytoxan, regardless of the MMR or MSI status. So perhaps adding something to the immunotherapy drug will make it effective regardless of MMR or MSI status. It's a very exciting time to be an oncologist. For decades, and I'm not talking about a few months, for decades, it's been the debulking procedure, 6 rounds of carboplatin and Taxol, and then, as so many of my patients have told me, waiting for the other shoe to drop, which is a metaphor for the advent of a recurrence. Now we have bevacizumab, we have PARP inhibition, and we have the extremely exciting arena of immunotherapy.